It's 7:05. I think we can start.
A very good evening to everyone. Let's start the session with Omkaram. Om. 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 Let us now continue with the NMO mantram. Natvaham kamaye rajyam, na swargam, na punarbhavam, kamaye dukkhatapnam, praninamurti nashanam. On the behalf of NMO Andhra Pradesh, I extend a warm welcome to all the participants and respected faculty members to today's Yellapragada Subbarow Clinical Campus session. This initiative serves as a valuable academic platform that encourages clinical learning, critical thinking, and interactive discussions among medical students, helping us grow into competent and compassionate healthcare professionals. Today, we have an interesting case presentation on thyroid swelling. The case will be presented by Ms. Bhargavi, a student of 2023 batch, NRI Institute of Medical Sciences, Vizag. We are privileged to have Dr. Y. Aditya V.S. Sairam, Sir, MBBS, MS, MCH, Surgical Oncology, Tata Memorial Hospitals, Mumbai, MRCS, who is a consultant surgical oncologist in Surya Global Hospitals, Amalapuram. Sir is the moderator and faculty for our today's session. Without any further delay, I request Ms. Ramya to kindly uptake the presentation.
Good evening, everyone. I'm Bala Bhargavi, 2K23 batch, and from NRI Institute of Medical Sciences, Visakhapatnam. So today I'm going to present a case of a patient with thyroid swelling admitted under Department of General Surgery. So during this presentation, I will discuss the patient's history, clinical examination, differential diagnosis, investigations, and also explain the clinical reasoning behind each step.
Okay, go ahead with your presentation.
Okay. Mrs. Ramalakshmi is a 42-year-old female homemaker, a resident of Visakhapatnam, who presented with swelling in front of her neck. Here, age is important because different thyroid diseases occur at different ages. In middle-aged women, multinodular goiter is common, whereas rapidly enlarging swellings in elderly patients raise suspicion of malignancy. And sex is also important because thyroid disorders are more common in females due to autoimmune mechanisms and hormonal influences. And occupation helps.
Bhargavi, can you explain which hormones influence why there is more female preponderance? And can you tell me some ratios that you know?
Yes, sir. Sir,
Why
actually,
it is more common in female? Why
sir,
thyroid diseases are more common in female?
a more imbalance will be seeing in females during puberty, pregnancy, and menopause. During this, the hormones from the anterior pituitary will also affect as the thyroid hormone will be also releasing from the anterior pituitary gland, and and some hormones like FSH, LH will be also be releasing from those. So due to this hormonal imbalance, it could be affected in females, sir.
Can you tell me some ratios that you know? How common it is in females when compared to males?
Um, Sir, in thyrotoxicosis, it is 8 times more common in females, sir.
So you can roughly tell between 8 to 10 is to 1%, 1
Yes,
between
yes,
when compared to females to male.
yes,
Okay,
sir.
and never reveal any patient identity as such. You told Rama Lakshmi and all that you should not tell.
Okay.
Okay,
Yes,
and you
sir.
should always tell it as a paragraph when you whenever you present this case presentations in your college or in exams also, you should always put it as a paragraph. Okay, never put it as bullet points. Okay.
Yes, sir.
Okay.
So here we are talking about occupation, so which helps assess risk factors such as radiation exposure or the impact of symptoms like hoarseness of professional voice users. And the next slide.
Bhargavi, 1 minute. How come this professional voice users related to thyroid diseases?
Sir, actually, in thyrotoxicosis, the individuals who are under more stress and strain, the thyrotoxicosis could occur in those individuals, sir. And even if people are working at radiation, so it could lead to some carcinomas, sir.
Okay, that and all is fine, but what about professional voice users? You told professional voice users, na? It is
Yes.
more common to see vocal cord pathologies rather than thyroid diseases in those patients. Okay,
Yes.
go ahead.
So the
And what
patient
about this? One more. Go back to previous slide. Then you told about the address. So what is the importance of residence?
Sir, actually, in few areas, the iodine levels will be lesser, sir, like in Himalayas. So, based
Hmm.
upon that, the address also plays a main role, sir. Even in the valleys, the content will be lesser, so it can be due to iodine deficiency, sir.
Yeah, correct. Because these Himalayan belt areas, they get all those drinking water supply from the Himalayas only, from the melting of the snow and all. That fresh water contains very less iodine. So to compensate that, the gland increases and goiter incidence is more common in these Himalayan belt areas. Okay,
So,
carry on.
uh, next slide. So, over the patient first noticed a swelling in front of the neck 5 years ago. The before slide. Okay. The patient noticed a swelling in the front of the neck 5 years ago. So it means it began smallly and the gradually the size is increased. And we can observe over the last 6 months, she developed difficulty in swallowing. So which suggests the compression of esophagus due to the enlargement of the thyroid gland. So, and she also complains of hoarseness of voice since 2 months. So, this can be due to the involvement of the recurrent laryngeal nerve. So, it could be either due to compression or direct invasion in case of thyroid malignancy, as you can see in anaplastic carcinoma of thyroid.
Not only in anaplastic, but in most of the other tumors also, there is quite common scenario that we can see there is some infiltration of the recurrent laryngeal. And do you think difficulty in swallowing is a common symptom?
No, sir. Actually, esophagus is a muscular structure, so it can be easily pushed away rather than compressed, sir. So most commonly
Mm-hmm.
we don't see dysphagia, sir.
Mm-hmm. Then what is the reason of dysphagia in this patient? What do you think is the reason for dysphagia?
Maybe the thyroid swelling is enlarged in a more way, so it could cause obstruction to the esophagus, sir.
Mhm. Between trachea and esophagus, which is the posterior, like immediate posterior structure to thyroid?
It is uh, trachea, sir.
Then it is uncommon to have dysphagia without having any dyspnea or something, without compressing the trachea directly. It is compressing the esophagus. It is like uncommon finding. It usually happens only when there is a large lateral goiter. When it is there, when both trachea and esophagus are pushed to one side, then only, and sometimes in case of malignant transformation, there will be some infiltration into the esophagus. Okay.
Okay. Yes, sir.
Yeah. Yeah. Okay, carry on.
Okay, sir. So the
So
swelling was
what I want to tell is when patient is telling about dysphagia, so kindly cross check whether it is truly dysphagia or she is confusing with some other symptoms, because dysphagia in a thyroid swelling is pretty rare. So whenever patient is telling that, you will just cross check with the patient whether it is truly the same thing or is she confusing with any other thing. Okay. Or if it is for difficulty in swallowing, how long it is there. Okay.
yes, sir.
Yeah, carry on.
Now we'll be going to the history of presenting illness. The first one is swelling. As we know, the swelling was first noticed 5 years ago, and it has a gradual onset and progressively increased in size in past few months. And we need to know about the onset because the gradual onset could suggest as multinodular goiter or benign conditions, whereas sudden onset can occur in infectious condition or inflammatory conditions such as hemorrhage or acute thyroiditis. And we need to know about the duration and rate of growth because it helps us to distinguish between benign swellings or inflammatory and malignant conditions. In benign conditions such as multinodular goiter, we can see slow growth, whereas in hemorrhage, thyroiditis, or in case of malignancy, we'll be seeing a rapid growth. The rapid growth in malignancy is due to as the cells divide rapidly and they invade the surrounding tissues. And we need to know about the regarding pain. We need to ask because most of the thyroid swellings are painless. This is because the thyroid capsule stretches slowly. So we need to rule out if the pain is present, it could suggest inflammation, hemorrhage, infection, and malignancy in some cases. And in advanced diseases, also uh, we can observe pain in patients, and even when the adjacent structures are invaded.
You are Ravi. Now tell me, how frequently do you think there will be some infection or inflammation in thyroid?
Sir, it is rare.
Why? Why it is rare when compared to other structures? You know,
No, sir.
one because it has a very thick capsule. Okay.
Yes,
Uh,
sir.
what is the layer that is investing the thyroid? What is the capsule is derived from? Derived from pretracheal layer of the deep cervical fascia. Okay, it is one of
Yes,
the thickest fascias in the neck, and it does not allow surrounding infections or this thing to enter into the thyroid. First thing. Second thing, it has a very good blood supply. Okay.
sir.
And third thing, it has very good lymphatics. Okay, all these things prevent any infection to settle in the thyroid per se.
Okay, sir.
Okay.
Yes.
What are the associated symptoms that you are telling?
So
Can you
those are
elaborate on the associated symptoms?
dyspnea, dysphagia, hoarseness of
Mhm.
voice, sir.
See,
Dyspnea is due to the
yeah, tell me.
dyspnea is due to the compression of the trachea due to the
Mhm.
enlargement of thyroid glands, sir. So
Mhm.
dysphagia, which is more uncommon, could occur sometimes, and hoarseness
Mhm.
of voice is due to uh,
Mhm.
paralysis of the recurrent laryngeal nerve, either due to compression or invasion, sir.
Very good. So only these structures do you think are the surrounding structures that cause these symptoms? These are called pressure symptoms. Okay.
Yes.
These are called pressure symptoms. So what other structures can you think of in this aspect? So one, the surrounding structures, one trachea you told, esophagus you told, recurrent laryngeal nerve you told. So what are the things that you can think of? What are the other surrounding structures that can cause some symptomatology of the pressure?
Sir, actually, carotid pulsation could be decreased or absent, sir, due
Mhm.
to the compression. So, when a large
Mhm.
thyroid swelling is present, and we call it
Mhm.
as Berry sign, sir.
Correct, correct. So
Yes.
even carotid compression or carotid infiltration can result in some symptoms. So what are those symptoms?
I have no ideas.
Oh, it could lead to TIS, transient ischemic attacks. Okay, any
Yes.
syncopal attacks. All these things you should ask. Okay,
Yes, sir.
so just divide this history into something like this: onset, sudden or insidious. Okay, what was the size of the swelling that she has noticed, and you have to compare it with something that everyone knows, like you should not tell it a small swelling or a big swelling, something like that. You should tell it with a, always have to compare it with something that everyone knows, like a size of a peanut or size of a some lemon size. Like that you have to compare, and it has started with that, and it has slowly increasing in size and attained the present size. Okay, over the
Yes,
period
sir.
of this and this, like this you have to tell. Never tell it like a points. Always case history should be like a storytelling. Okay.
Sir.
That should be like some Mrs. XYZ of so and so age of residency of this place. She was housewife by occupation, has presented to her surgical OPD with chief complaints of this and this since these many days. Okay, like this it has to come. Okay,
Sir.
always make a habit to tell like that. Okay, that tells that you have good communication skills, and you know how to put up a case for examination. Okay,
Yes, sir.
yeah, continue.
Next slide. So in this case, we have noted that the swelling was noticed 5 years ago with a gradual onset and progressive increase in size, which is initially painless, and there is no history of trauma or no fever.
Why you have
Next,
asked for history of trauma?
uh, sir,
What
due
trauma
to
can cause this long-standing thyroid swelling or any neck swelling?
uh, sir, actually, thyroid trauma is very uncommon, sir. So, but
Mm-hmm.
sometimes it can, like penetrating injuries or blunt neck trauma could occur in road traffic accidents or even like sport injuries or direct fall on the neck, sir. So, so maybe
Unlikely,
due to
very
that,
unlikely.
yes, a very uncommon. But to
Hmm.
rule out everything, we need to ask regarding that, sir.
Oh. Okay, ठीक है, carry on.
So, so we need to look for the pressure symptoms such as dysphagia, dyspnea, stridor, and hoarseness of voice. So, as we already discussed before, so
So
after,
in a
so
thyroid case, always you have to divide history of present illness, then comes the pressure symptoms, then comes the functional symptoms, then comes the metastatic symptoms. So you divide like that. Okay.
sir, yes.
Yeah, continue.
Um, in the before slide, we have also mentioned the stridor. The stridor is a very significant upper airway obstruction, and it requires an urgent attention because it is due to the severe tracheal narrowing, and which tells us there's a possible airway compromise, so that it's a surgical emergency.
Okay, how do you differentiate between a strider and a horse? Two things are there, right?
Yes, sir. Stridor. Stridor is
Can
a
you tell the
whistling.
difference between both?
Yes, sir. The stridor is due to a narrowing of narrow due to tracheal compression, sir. So it is a like a whistling sound, sir.
Mm-hmm.
Yes,
It's
sir.
not whistling sound, but it is because of trachea narrowing, and whatever the expiration goes through it, it causes lot of rough noises. Okay.
Yes, it is a high pitched noise, sir.
Yes. Hmm.
Yes. Whereas
And
in
what is
the
hoarseness?
horse,
What is the
the
mechanism of hoarseness?
it is due to the compression or invasion of recurrent laryngeal nerve or vocal cord paralysis, sir, which leads to that.
Mm-hmm. Mm-hmm.
In hoarseness
Mm-hmm.
of voice, which we'll observe the change in quality of voice, sir, due to the vocal cord dysfunction, due to the compression of
Mm-hmm.
recurrent laryngeal nerve. So
How
the
do you ask
voice,
it? How do you ask to a patient? You can't ask directly, na? Do you have hoarseness? You don't ask like that, no? You have to explain what is hoarseness to a patient. So how do you explain it?
We'll ask if you have any change in voice, like rough or weak voice, do you have in recent times?
You have to ask in such a way. You should not use any medical terms because patient doesn't know any medical terms. So you have to ask that is there any recent change in voice quality? Okay,
Yes,
that
sir.
way you should ask, and the same way you should keep it in your case history also. Okay,
Yes,
that
sir.
tells that you know how to communicate with the patient. Okay, you just
Yes,
didn't
sir.
write it from the book. Okay.
Yes, sir.
Okay, why Strider is emergency?
Sir, it could causes like airway compromise could occur, sir.
So when thyroid is causing Strider, okay, how do you treat it? How do you handle that emergency condition? Patient comes with you with a huge thyroid, okay, which is
Mm.
causing Strider. Strider causing thyroid swelling means it will be little huge only. Okay.
Yes, sir.
And how do you manage it? It's an emergency condition. Patient will be coming to your OPD. You are a treating doctor there. Patient comes to you with respiratory distress and he collapses with Strider in your OPD.
Yes, sir. Sir, actually, we need to go through the ABC approach, sir. So the first priority would be airway, sir. So as
Mm-hmm.
spider is due to the severity of airway obstruction, we need to give
Mm-hmm.
oxygen at high flow, sir. So
Do you think that oxygen will reach his alveoli?
if if the if the severity is more, sir, we could go for endotracheal intubation or emergency tracheostomy, sir. If intubation is not possible,
Endotracheal intubation and giving oxygen won't help in case of Strider. Okay,
tracheostomy.
it just tracheostomy is a treatment of choice, but they just give us time to act. Okay, oxygen, giving 100% oxygen, high flow oxygen can give us some time to act to arrange for the tracheostomy. Okay,
Sir.
so have you seen anyone doing tracheostomy
No,
anytime?
sir. No, sir.
Okay, okay. And this may be a little higher level for UG. So let's move forward. Okay, tracheostomy is a treatment for Strider, but until the time you arrange for tracheostomy, you can give high flow oxygen, maintain BP, give fluids and other stuff. But this is a quite emergency condition. Okay, at least you need to do at least needle tracheostomy at least. Okay,
Yes, sir.
fine. Carry forward.
Next slide. So after this, the history of present illness. So we need to inquire about the symptoms suggestive of hyperthyroidism. This is important because some thyroid swellings are associated with excessive production of thyroid hormones, as you can see in Graves' disease or toxic multinodular goiter. So we need to ask about weight loss, heat intolerance, excessive sweating, palpitations, tremors, increased appetite, anxiety, and increased bowel frequency. So,
Hold.
because hypothyroidism increases the sympathetic nervous system activity, so we need to ask all these questions for them.
Okay. Now tell me weight loss. Yeah. Do you think it is you should be able to ask about appetite also here?
Yes,
You
sir.
should combine
Uh,
weight loss and appetite together. It is not increased appetite. It is normal appetite. Okay. There will be
yes,
weight loss despite of normal appetite. Patient will be telling I'm having same appetite as before also, but I'm started losing weight. Okay. So tell me where you will have weight loss and also loss of appetite both.
sir, in malignancy conditions and
And any liver failures features. Okay. Any liver pathology and in malignancy. Okay.
yes, yes.
Okay. Can you tell me what do you know by the term significant weight loss?
Uh,
How much weight loss is called significant weight loss?
uh, like within 6 to 12 months, the body weight should be decreased more than 5% of the body weight, sir. Or else,
5% in. Tell me. Hmm.
so for example, if a person is weighing 60 kgs, so the 5% loss means in this case, um, 3 kgs, sir. So if the person is unintentionally losing the weight, this 5% is in within 6 to 12 months, we can call it as clinically significant weight loss, sir.
There is some change, okay?
Yes.
It is not like 6 to 12 months. Okay, 10% of body weight in 6 months or 5% of body weight in 1 month.
Okay, sir.
Okay, that is the definition of significant weight loss. Okay, now tell me what is heat intolerance? How do you ask heat intolerance to a patient?
Uh, sir,
You're also from Vizag. Remember, patient is also from Vizag.
yes, sir. So the patient will feel uncomfortable, sir, in excessively hot temperatures.
Everyone will feel uncomfortable in excessive
Mm.
hot
Yeah.
temperature.
He says that I
Okay.
can't stay in a warm room and prefers a more cool environment, like always fans or air conditioners when compared to others. Even other people doesn't want them.
Okay. So it's like
And
this.
even the
You should
sweat.
always you should always ask the patient with his previous habits. Okay. Is there any recent change in heat preferences? Okay. That you should ask. Okay.
Yes,
Like
sir.
within 6 months, before you used to feel comfortable at the same temperature. Now you are feeling uncomfortable in the same temperature. That is important. Okay.
Yes, sir.
No. Then, okay. How did you ask for tremors? Do you ask tremors in history taking?
Yes, sir. Uh, like we need to like are your hands shaking frequently, or when you're holding the cup, are you like shaking the cup or trembling it in the daily activities? Is it in like is it interfering with your daily activity, like while holding some cups or utensils or clothes like that, sir?
Cups, utensils, holding and all will require some more amount of energy, which will overcome the tremor action. Okay. Best thing you should ask, is there any recent change in handwriting? Okay.
Yes, sir.
Patient, when we hold pen, we will hold it lightly, we will not hold it too hard to overcome the tremor. So if you ask the patient like that, while you're holding a pen, are you having any shaking, and that leads to change in your handwriting or change in your signature, that will tell more relevant history, because these are all what kind of tremors in thyroid that we get. Is it coarse tremors or it fine tremors?
Fine tremors.
Yes. Then fine tremors, how can you elicit with all the other things which can overcome, which use a lot of excessive muscle power?
Yes.
Okay. So
Yes.
ask him whether there is any recent change in handwriting or signature. Okay.
Okay, sir.
Yeah.
Uh,
Carry on. And instead of increased bowel frequency, the best term would be diarrhea. Okay. Patients with hyperthyroidism will have diarrhea. Increased bowel frequency is a different thing altogether. Okay.
yes, sir.
Go on.
The next slide. So next we need to inquire about symptoms of hypothyroidism. So because in some thyroid disorders, they'll be resulting in decreased thyroid hormone production. So we need to ask about weight gain, cold intolerance, constipation, fatigue, dry skin, hair loss, hoarseness, menorrhagia, and facial puffiness. So we need to ask about constipation because in hypothyroidism, the intestinal motility slowly decreases. So we need to ask about easy fatigability, dry skin, and hair loss, as is a common manifestations of hypothyroidism.
There will be hair loss. You know the
Uh,
mechanism behind it.
Sir,
Because
sir, thyroid hormones will be play a role in growth of the hair also, sir. So they regulate the hair follicle growth, sir.
yeah,
So it,
thyroid hormones play important role in cell cycle regulations, uh, cell reproductive things. Okay, how fast the cell divides and all. Okay, when the
yes,
hair uh, stem cells division is less, then there will be obviously hair loss. Okay,
yes, yes, sir.
so menorrhagia and all we have already discussed. So what is the similarity between TSH and FSH?
Uh,
Is it just that they arise from the same part of the pituitary gland, or is there something else biochemically also, structurally?
sir, these are glycoprotein hormones. They are.
Okay, or most of the hormones are glycoproteins only.
So
Why these two?
they both bind to the G protein coupled receptors, sir.
Almost all the hormone receptors are G protein coupled only, surface membrane receptors. These both share same beta units. Okay, there is alpha and beta units. Okay, the beta units of these two hormones are same. Okay, that's why there is some cross reactivity between these two hormones. Okay,
Yes.
yeah.
Next slide. So we need to ask about the past medical history also. So we need to ask previous thyroid disease or any thyroid surgery because these may indicate a recurrent disease or influence the surgical approach. And we can inquire about the previous radiation exposure to the neck as it is a known risk factor for the thyroid malignancy. And we need to know about diabetes mellitus, hypertension, tuberculosis, and other chronic illness as this condition may affect the perioperative management. And we need to ask history of certain drugs which can alter the thyroid function, and also
Bhargavi,
any drug.
do you think your present history has been completely done? History of present illness?
Yes, sir.
Did you mention about the metastatic symptoms?
Actually, I have mentioned in the general examinations, sir.
It has to come here. Symptomatology for malignant things must come here in the present
Yes, sir.
history only. Okay. So as I told earlier, I'm repeating it again. For thyroid, history of present illness must contain elaborated details of the chief complaints along with pressure symptoms must come after that along with these functional symptoms like hyper or hypothyroidism symptoms and followed by malignant symptoms must be there. Okay. Whether they're
Yes,
present
sir.
or not, you have to mention it in the history of present illness itself. Okay. Because thyroid is a pretty common disease and you will get definitely get it in an exam for evaluation. Okay. Never
Sir.
forget to put malignant symptoms in the present history. Okay.
Sir.
Okay. Coming
So
to past history. Yeah. What kind of neck irradiation are you talking about, and how long ago it should have been given to the patient to develop any thyroid cancer now?
uh, sir, because prior exposure to the ionizing radiation, as it is a risk factor of thyroid malignancy, the radiation can damage the DNA of thyroid cells, sir. So so it increases the risk of thyroid cancer, sir. So most commonly,
Do you think? Yeah. Tell
yes,
me. Tell me. Tell
in
me. Continue.
papillary thyroid carcinoma, it plays an important role, sir. As in that, it is a major risk factor, sir. So
Okay.
when the radiation exposure is during the childhood, the risk is more, sir, and
Mhm.
the carcinoma can develop 10 to 40 years after the exposure, sir.
Minimum of 10 years like that is there in studies, but can occur even earlier also in some patients. So what kind of disease you use irradiation?
Sir, in childhood cancer such as lymphomas, we can use it, sir.
in case of Hodgkin's lymphoma, they use irradiation called mantle radiation. Before, nowadays, most of them are not giving it. That covers neck and thorax. Okay, that radiation. So early exposure to these kind of ionizing radiations can predispose for thyroid malignancies of later in life, like 10 years. Okay.
Yes, sir.
So how about this diabetes, hypertension, all these help you in history taking and managing the patient?
Sir, if we wanted to go for a surgery, we need to know about those, sir. So, which
Mhm.
could, as it could influence the patient fitness for the surgery, sir. So, if the
Yeah.
diabetes is not controlled properly,
Good,
the
good. Okay.
risk of the
Okay, I know that you know all this. Then what about anti-thyroid drug intakes? What anti-thyroid drug intakes you ask for?
uh,
No, any
propylthyroid
yeah, propylthiouracil and
radioactive iodine,
one drug,
carbimazole,
propylthiouracil.
methimazole,
Yeah,
carbimazole,
carbimazole,
methimazole.
Okay, among these three, which is the preferable
Yes,
drug, do you think? Oh,
sir.
hmm. Which anti-thyroid drug is more preferable among these three that you told? Among
Carbimazole,
propylthiouracil, huh?
uh,
Pardon?
pro- carbimazole, sir.
Methimazole is more preferable, carbimazole and methimazole compared to propylthiouracil. You know why?
No, sir.
Methimazole has longer half-life, okay? Even you can use it as a OD dose also, like once a day dose also. For propylthiouracil, you need to give more doses in a day. So the compliance decreases. You need to take 3 doses every day. You may miss 1 or 2 doses someday, okay?
Yes, sir.
Yeah, okay. So, okay, carry on.
Next slide. So then we need to ask about the personal history. We need to ask the patient's diet because we need to know the nutritional status and iodine intake as these are relevant to the thyroid health. And we need to ask about the appetite since increased appetite may occur in hyperthyroidism, whereas reduced appetite may be associated with hypothyroidism or malignancy. And we need to ask about the bowel habits because hypothyroidism can increase bowel frequency while hypothyroidism commonly causes constipation. So addictions like smoking and alcohol consumption also affects the thyroid gland. So as in like Graves disease also, and the lifestyle factors are also important in overall patient assessment.
Bhargavi. Now tell me, what are the diets that cause thyroid hypothyroidism
uh, Sir, uh, let
and the mechanism also you well,
um, sir, it is due goitrogenic foods, sir, like cabbage, cauliflower,
mhm, mhm,
radish, broccoli, sir.
mhm,
Uh,
mhm. What is the mechanism? Why? What is there in those food items? Broccoli is pretty famous nowadays.
uh, Sir, this contains some substances which interfere with the thyroid hormone synthesis, sir. So, so
I'm asking
that
which.
the iodide uptake will be reduced by the thyroid gland and also inhibit the main enzyme that is thyroid peroxidase, which is needed for the production of T3 and T4 hormones, sir.
Okay, these contain thiocyanins. Okay,
Yes.
which have same like its the chemical name is like CN minus. Iodine is I negative, right? I minus. Same like this thiocyanins has CN minus. They go and interfere with the sodium iodine importers. And also they inhibit this peroxidase enzyme. Okay.
Yes.
And these are all seen in uncooked foods, okay, not in cooked one. We usually use most of the times cooked material, so these thiocyanins get deactivated during cooking process. These are all in Western countries where they eat a lot of salads with raw broccoli, cabbage, and all. Those patients can develop hypothyroidism later if there is prolonged usage of these raw things. Okay.
Yes, sir.
Yeah. Go on.
Next slide. So, as the patient is a woman of reproductive age, I obtained the detailed menstrual history. So, we need to ask the age at menarche, the last menstrual period, the cycle regularity, duration and amount of bleeding, dysmenorrhea, if any passage of clots are occurring, the number of pads usage per day, and the menopausal status. Because uh, the thyroid hormones play an important role in regulating the menstrual cycle. So, hypothyroidism patients will be presented with menorrhagia, whereas hyperthyroidism patients may cause oligomenorrhea or amenorrhea. So, we need to ask about menstrual history.
Go on.
Yes, sir. Next slide. So, we need to also obtain the marital and obstetric history. We need to ask the patient is married or unmarried, the duration of marriage, whether it is consanguineous or non-consanguineous marriage. So, because the marital status is important because it provides the uh, context of the reproductive health, and we need to also inquire about the obstetric history, including the number of pregnancies, deliveries, any abortions, and live children. And as we know that thyroid disorders can affect fertility, pregnancy, and even the fetal development. So we need to also ask about the infertility or recurrent miscarriages and any pregnancy complication uh, that has occurred, as these may be associated with untreated thyroid disease.
Okay, Bhargavi, now tell me what is the significance of this consanguineous and non-consanguineous marriage?
Sir,
Do you think it is relevant in our case?
uh, sir, few thyroid disorders has a genetic predisposition in so, like some are autosomal recessive disorders could occur, sir. So which can cause congenital hypothyroidism, sir, or inherited defects in thyroid hormone synthesis, sir.
Okay.
Yes.
Have you heard about any syndromes called men syndromes?
Sir,
Have you
I
heard
can
about any symptoms called men syndromes?
mention symptoms. Yes, sir. Multiple endocrine neoplasia. It is an
Correct.
autosomal dominant one, sir.
What kind of
It is
malignancy, thyroid malignancy you get in those?
so medullary thyroid carcinoma can occur, sir.
Mm. And they're important in consanguineous marriages and all. And do you know any other syndromes that you know where you get other than medullary thyroid cancer?
No, sir. Sir,
Okay.
apart from the thyroid, sir.
Apart from medullary thyroid, where you can get follicular and papillary thyroid cancers also. There are few syndromes called Cowden syndrome, FAP syndrome. Okay. All these syndromes you will get papillary and follicular neoplasms more common. Okay. Only in men you get medullary thyroid cancers. Okay.
Yes,
Okay. And abortion history is important and infertility history is important. Rest of all are not much significant. Okay.
sir.
Yeah. Carry on.
Next slide. So we need to inquire of the family. So because it is important in several thyroid diseases as it has a genetic predisposition, and even we need to ask the thyroid swellings or thyroid cancer and any autoimmune diseases in family members, because some conditions like Graves' disease, Hashimoto thyroiditis, and some thyroid cancer tend to occur in families. So this information helps us assessing the patient's inherited risk.
Okay, move on.
The next slide. So thus, while taking the history, we need to specifically look for the evidence of thyroid dysfunction, the risk factors for malignancy, and any previous thyroid disease and associated systemic illnesses and hereditary predisposition. So in our patient, these histories were non-contributory, supporting a likely benign euthyroid swelling. So coming to
Okay,
the
so
general.
before going to general examination, always try to summarize the history, okay, in just a para with only the positive findings in it, okay? So from history, what do you think are you dealing with right now?
Uh, Sir, I think it's a benign swelling, sir.
Why? Why benign swelling? 5 years now, there is some recent change in hoarseness of voice and all, and there is dysphagia also,
Sir,
which you think it is
it
benign.
started as benign and maybe it was progressing to malignant condition, sir.
Uh, it might have started as benign 5 years ago. Slowly, there might be some transformation in the recent time, okay, leading to
Yes, sir.
dysphagia and hoarseness, okay.
Yes, sir.
Benign diseases causing hoarseness is not very common, okay. When you're telling hoarseness in within presence of a thyroid swelling, always keep malignancy in the play, okay.
Sir.
Okay, so from your history, you think it is could be some long-standing goiter turned into some malignancy, right?
Yes, sir.
Now keep that in mind and start presenting the general examination.
Okay, sir. The before slide, please.
So always when you start before starting general examination, keep a habit of giving a small summary of all your findings. Okay, so some important things like in thyroid, what are important? Age is important, sex is important, and how long the duration is, recent change in times. Okay, change of symptoms, any pressure symptoms. Only those important things you need to highlight and tell it as a small para. Okay, that
Yes,
helps
sir.
to because examiner will not follow all your history. Okay, if you
Yes, sir.
summarize them before starting your general physical examination, not even in thyroid, in any case, in any subject, okay, it gives the examiner an idea. Okay, okay, this is the thing. Okay, like that. Okay. Otherwise, examiner will think you didn't tell me that, you didn't tell me this, even though you might have told. Okay.
Yes, sir.
So try to make it a habit in future cases also. Give a small summary after the presenting history and all is done. Okay. Only the
Sir.
important things that help you to make a decision in the patient management. Okay.
Yes, sir.
Yeah.
So on general physical examination, we need to look if the patient was conscious, cooperative, and well oriented to time, place, and person, and the build and nourishment of the patient, their height and weight we need to be recorded, and so that we can calculate the BMI and vital signs should be seen. So here,
One more thing.
we
One
are.
more thing. Bhargavi, 1 minute. One more thing you forgot to tell is the socioeconomic status of the patient in the uh, history taking. That is very important because that will have treatment implications also. Okay.
Yes,
Never
sir.
forget to tell socioeconomic status of the patient. Okay.
Yes, sir.
Okay. Now tell me difference between built and nourishment.
Uh, Sir, the build is like the person is lean or like obese.
It comes under nourishment. Built is like you're talking about the basic skeletal structure of the patient.
Yes, sir.
Whether there is any deformity, spine deformity or anything. He's not very tall or is very short. Okay,
Yes,
that
sir.
kind of skeletal image should come in the built thing. Nourishment comes with the other things, like he's bulky, he's muscular, he's lean. Okay, he's malnourished. Okay, he has the skin malnourished, changes in the skin, nails, etc. Okay,
Sir.
always think like that. Build is the skeletal thing, nourishment is the other nutrient things like muscular, proteinaceous thing or not. Okay, have you heard the word sarcopenia?
Sir,
You heard the term called sarcopenia?
yes, sir. It is a loss of progressive loss of skeletal muscle mass, sir. The muscle
Mm-hmm.
strength and the performance will be decreased, sir.
Yes, yes. So that tells about the nourishment part. Okay, sarcopenia comes under the nourishment part.
Yes, sir.
Yeah, carry on.
Yes, sir. So, we before slide. So we are here mentioning that conscious, cooperative, and well-oriented or not, because it could reflect the patient's overall clinical status and ability to provide a reliable history. So, if any altered sensorium is present, it may indicate some severe systemic illnesses. And we are assessing the built and nourishment because it gives an idea about the thyroid function. And in usually euthyroid patient, the poor nourishment with weight loss is seen, and which suggests hyperthyroidism or malignancy. And if the person is obese and weight gain is present, it suggests hypothyroidism. So coming to the BMI, so it provides assessment of nutritional status. Like in low BMI, the person may have hyperthyroidism or malignancy, and in case of high BMI, the person can have hypothyroidism. As we know, it contribute to the weight gain. And we need to check the temperature because if there is any raise in temperature, like that is fever, it could suggest infection or inflammation, as in case of subacute thyroiditis. And the vitals are very important here. So is the pulse, because it gives a clue about the thyroid function. If the pulse if you have tachycardia, it is due to maybe anxiety, fever, or hyperthyroidism. And if the bradycardia is seen in the patient, it could be due to hypothyroidism. And
Bhargavi, hold. Uh, Describe only pulse. How do you tell in the examination?
um, sir, we need to say about the rate, rhythm, and volume characters, sir.
Mhm. Hmm.
Radio radial delay and radio femoral delay, and equality, sir.
Mm-hmm. Do you think
Yes.
radio femoral, these are all not required in thyroid case? You can do it in CNS examination and all later. For any CNS case, for this case, it is not required. Important things are the rate and the volume. Okay.
Yes, sir.
And where do you think there will be change in rhythm in thyroid
Uh,
cases?
in hyperthyroidism, the rhythm can be irregular, sir. Because in hyperthyroidism, atrial fibrillation occurs, sir.
Why?
Uh, Sir,
What it is
the
called?
cardio.
Do you
Uh,
know primary and secondary thyrotoxicosis difference?
yes, sir. In primary toxicosis, it mainly affects the CNS system, sir.
Hmm?
So,
Symptoms will
whereas
be
in CNS, uh, Oh,
Symptoms will be related to CNS systems like irritability, anxiety, tremors,
anxiety.
etc. Okay,
Yes, sir.
because of the increase in the nerve excitability.
Yes.
Then what is secondary thyrotoxicosis?
In secondary thyrotoxicosis, the cardiovascular system is mainly affected, sir. So, as in due to excessive thyroid hormones, the heart sensitivity will be increased, sir, to
Hmm.
catecholamines. So,
Correct.
which could causes a increased beta receptor sensitivity, and the atrial
Leads to
muscle becomes
fibrillation,
more, sir.
excited. Yeah, correct. Atrial
Yes,
muscle
sir.
becomes more excited, leads to atrial
Sir.
fibrillation.
Yes,
Hmm.
sir.
Yeah,
And
move
even
on.
there is a atrial refractory period will be shortened, sir. As the electrical impulses will be re-entering the circulate and abnormally.
Carry on.
Yes, sir. So next we need to ask about the blood pressure. The before slide. So we need to ask about the blood pressure. As in hyperthyroidism, we can see increased systolic BP, and whereas in hypothyroidism, we can see increased diastolic BP, which can occur. That's and the in hyperthyroidism, the systolic BP is increased because, as we know, the thyroid hormones increase the cardiac output and stroke volume, and we need to check for the respiratory rate, as it can the increased respiratory rate.
Hold, Bhargavi, hold.
Yes.
So when you are talking about BP in case of hyperthyroidism, you talked only about the systolic. What about the diastolic BP? Will there be any change in diastolic BP?
uh, Sir, it could be normal or decreased, sir.
It will be decreased.
Sir, because as thyroid hormones will be causing vasodilation, sir. So
Correct.
yes.
So that's
So
why there
that's
will be decrease in diastolic
systemic
BP. So what it
vascular.
will cause when there is an increase in systolic BP and decrease in diastolic BP?
Sir,
What it is called when there is an increase in systolic BP and decrease in diastolic BP? What it is called? What condition is it called? Called widening of pulse pressure. Okay,
yes, sir.
and it causes what? Collapsing pulse.
Okay, sir.
Yeah,
Yes.
go on to respiration. You were telling about respiratory rate. Come on.
Yes, sir. So if there is a increased respiratory rate, it could be due to tracheal compression, as dyspnea can occur in tracheal compression, and respiratory distress, or even severe hyperthyroidism.
Because of changes in because secondary thyrotoxicosis also there will be dyspnea. Okay.
Yes, sir.
Hmm.
Next slide. So we'll be looking for pallor because the patients with thyroid disease may have anemia. So as in patients of hypothyroidism, it could cause iron deficiency anemia, vitamin B12 deficiency. Uh, so we need to look for pallor also. As we know that the thyroid hormone, if the thyroid hormone is reduced, it also affects the erythropoietin production, and could be also associated with some nutritional deficiencies. The next is icterus. We need to see it is present or absent. Usually in thyroid in patients, it is absent. But if the icterus is present, we need to think of liver diseases or any drug-induced liver injury, or any hemolysis have occurred. So some
think
anti-thyroid
we can
drugs.
fast forward all these things because this will take time, but it will not do much in thyroid cases. Okay, pallor, icterus, clubbing, and cyanosis are fine. Okay,
So,
move on, move on to next slide. This is
So
more
after
important. More about this.
yes, sir. So after completing the general physical examination, we need to proceed with the local examination of the thyroid gland. So before proceeding that, we need to make sure that the patient was seated comfortably with the neck adequately exposed from the mandible to the clavicle. And we need to make sure that adequate lighting is present and the examination was performed systematically. First, we need to start with inspection, then
1 minute.
palpation.
1 minute. So the exposure should be from mandible to nipple level. Okay. Because you need to
Yes.
see the manubrium also, not until the clavicle.
Okay, sir.
Move on. Next.
Sir. So we need the patient should be in sitting position. It because the thyroid gland is more prominent in sitting position and making the inspection palpation easier, and it also allows the better assessment of movement during the swallowing. So coming to the inspection, um, we could say a diffuse swelling was noted in the lower anterior part of the neck in this patient. And why do we look at the site in the inspection? Because the anatomical location helps identify the origin of the swelling. For example, if the swelling is in the midline, we need to think of thyroglossal duct cyst or thyroid swelling. And if the swelling is present toward the lateral, we need to think of the cervical lymph nodes, the carotid body tumor. And if the thyroid swelling is usually the thyroid swelling is present in the lower anterior neck because the thyroid gland and lies anterior to the second to the fourth tracheal rings in the lower part of the neck. And next we need to note the size because as the large swellings may cause the tracheal compression, which causes dyspnea, esophageal compression, and cosmetic deformity. And and even rapidly enlarging swellings may suggest malignancy or hemorrhage into a cyst. So next we need to look for the skin changes. Um, Normal skin usually suggests a benign lesion. So if any skin ulceration, fixation, or redness is present, we need to think about malignancy infection. So the skin fixation is very significant in thyroid cases as it suggests the invasion of surrounding tissue, which is a feature of advanced malignancy. We need to look for scars because a scar will indicate previous thyroid surgery and previous any drainage procedure or recurrent disease. And we need to look for dilated veins. So because if any dilated veins are present, it suggests superior vena cava obstruction, venous congestion, or retrosternal goiter. And why do the veins dilated? Because the compression of the major neck veins impairs venous drainage, so which causes congestion and dilatation. And we need to look for visible pulsation, but these are very uncommon, and if they are present, it could be due to vascular thyroid swelling, Graves disease, and aneurysm, which is a very rare. And Graves disease produce visible pulsation because the gland is highly vascular, leading to increased blood flow. We need to ask the patient to swallow sip of water. So, because as we know, thyroid gland is attached to the larynx and upper trachea by ligament of Berry. So, during swallowing, the larynx elevates. The thyroid moves with it. So, we could observe the thyroid swelling very clearly.
Okay. Now, tell me why when there is an increase in the thyroid swelling, why the thyroid doesn't grow upwards. Instead, it grows only downwards. Why?
Uh, Sir, I have no idea about it, sir.
So you know that thyroid is covered by a thick capsule, right?
Sir.
So it attaches to the oblique line that is present over the thyroid cartilage. Okay.
Yes.
So
Yes.
that prevents the if there is any swelling, usually it has to grow in all directions, right?
Yes, sir.
When there is no resistance. But in case of thyroid, the growth towards upper side is restricted by this attachment of the thyroid capsule to the thyroid cartilage. Okay, oblique line of thyroid cartilage. So whatever swelling is there, it starts growing downwards and goes into the retrosternal area and causes this venous engorgement and all. Okay.
Yes, sir.
Okay. Uh,
So,
yeah,
sir.
movement with the swallowing.
Yes, sir.
You told correctly that it is attached to larynx. So why does larynx move with deglutination? Why?
Uh,
Where does this Berry's ligament get attached to? Within the larynx, where it gets attached? It attaches to the cricoid cartilage. Okay. And during deglutination, you know superior, middle, and inferior constrictors of pharynx.
yes, sir.
What is the inferior constrictor is made up of two muscles. What are the two muscles?
Uh,
Crico and thyropharynx, right?
yes, sir.
So during deglutination, when this inferior constrictor also contracts, this cricoid gets lifted up. That's how larynx also goes up during deglutination. Okay, that's why thyroid also lifts up. So you should also tell it is not moving with protrusion of tongue. That also you should tell, but better to tell it
Yes,
in the palpation only. Okay.
yes, sir. Um, so here we have a few methods. That is Physilos method. So which means here we need to ask the patient to place the both hands behind his head. The finger should be clasped over his occiput and ask the patient to push his head backward against the hands. So to make the thyroid gland more prominent. So we can inspect that one. And next is the as before we have discussed the will be asking the patient to swallow, and after that we need to differentiate the thyroid swelling from thyroglossal fistula, because in thyroid swelling, the there'll be there'll be no movement of the thyroid after protrusion of the tongue, but whereas in thyroglossal fistula, uh, due to the it moves due after the protrusion of the tongue. This is because it is connected to the foramen cecum by the remnants of the thyroglossal duct, which is attached to the thyroid, which is attached to the hyoid bone and tongue. So, if there is a movement with swallowing, confirms that the swelling is attached to the thyroid origin. So, but if the swelling is moving with the protrusion of tongue, it suggests more of a thyroglossal fistula.
Tell me, how do you check for protrusion, swelling moving with protrusion of tongue again?
Sir,
Can you describe me how do you check whether the swelling is moving with protrusion of tongue? There are two things here. First, you need to catch hold of the swelling in your hand, okay,
yes,
and
sir.
ask the patient to open the mouth. Okay, that is the first part.
Yes, sir.
Second part, you have to ask the patient to protrude his tongue out.
Yes,
And you
sir.
will feel whether that swelling is moving along with the tongue, along with the protrusion of the tongue or not. Before that, you have to hold the swelling in your hand between your fingers. That's why I told it is better to tell it in the palpation. Okay.
Yes, yes.
Hmm. Move on.
Next slide. So after the inspection, we need to proceed with the palpation. So here we need to stand behind the patient and examine the thyroid gland. So first we need to confirm all the inspectory findings and then assess the local temperature, tenderness, the surface, borders, consistency, mobility, lower border and position of the trachea. So we need to stand
Minute.
behind the patient.
1 minute. Go back to previous inspection slides. Previous slide. Previous one. You never mention whether the lower limit of the thyroid swelling is visible or not. That should be written, very important, because you should always see whether the goiter lower limit is above the sternal notch or not. That you have to tell it in inspection only. Okay. Are you there, Bhargavi?
Yes, sir.
Right. Go on to palpation now.
So we need to stand behind the patient, because standing behind the patient allows us that both the lobes of the thyroid to be palpated simultaneously, and thus it provides a better control while the patient swallows. So we need to confirm the inspectory findings, because as you know, the inspection only provides a visual information. So while palpation, it confirms the exact size, consistency, extent and mobility of the swelling, and the local temperature and tenderness should be examined. And if the local temperature, uh, i- is there any increased temperature or normal? So if there is an increased local temperature, it could suggest like inflammation, infection, and in normal temperature, it could favor the benign goiter, thyroid nodules, and most thyroid cancers. So in subacute thyroiditis and acute suppurative thyroiditis, we could observe the raised local temperature. And why do we check for tenderness? Because as we know, most of the thyroid swellings are painless. So in the as we have already discussed, and if tenderness is present, it could suggest inflammatory causes or infectory causes such as thyroiditis, hemorrhage into thyroid cyst. So the thyroid carcinoma uh, is usually painless, so tenderness occurs only in inflammation. The surface and borders should be noted. It is smooth or nodular or well defined or ill defined, because it suggests, if the surface is smooth, it suggests a diffuse goiter or simple thyroid enlargement and nodular surface. But whereas the nodular surface suggests multinodular goiter or thyroid neoplasm. In multinodular goiter, the surface is irregular because of hyperplasia. There will be a repeated cycle of hyperplasia, and which causes the production of more multiple nodules of different sizes. So to assess the border, uh, if there is a well-defined borders, it suggests a localized and benign lesions, and if it is ill-defined, it indicates malignancy, and even invasion into surrounding tissues should be known. So the malignant swellings are ill-defined because the malignant tumors, as we know, they infiltrate the adjacent tissues, making the margins indistinct. We need to know about the consistency. Is it soft, firm, hard, or cystic? So it because the consistency gives us the clues about the pathology. If the consistency is soft, it could be due to diffuse toxic goiter. Uh, in multinodular goiter, we'll be seeing the firm consistency and even Hashimoto thyroiditis. And in carcinomas, we'll be seeing a hard consistency. And in thyroid cyst, we'll be having a cystic consistency. So why does in thyroid cancer we have a hard consistency? Because It is due to the thyroid carcinomas undergo fibrosis and infiltration to the surrounding tissues. So next, we need to know about the mobility. So if the swelling was freely mobile and moved with deglutination or not, because it could so the mobile swelling, if the swelling is mobile, it could be usually benign. If the swelling is fixed, it usually suggests malignancy and invasion in the muscles or surrounding tissues. So here we have a question that why does thyroid cancer becomes fixed? As we know that malignant cells can infiltrate adjacent muscles, fascia, and surrounding structures. So which causes the reduced mobility. And the lower border of the thyroid should be palpable. Should be seen. Is it palpable or not palpable? So if not palpable, the lower border could not be palpated, which raises suspicions of retrosternal extension. So which so in retrosternal goiter, we can't palpate the lower border of thyroid because the thyroid extends into the superior mediastinum behind the sternum, so making it inaccessible to the palpation. So we'll be examining the trachea. So an enlarged thyroid pushes the trachea to one side, so which compresses the airway. So which is very important before planning any surgery. So a unilateral thyroid swelling deviate the trachea. So because a large thyroid mass exerts pressure on the trachea, displacing toward the opposite side. So if you find any hard swelling or fixed swelling and hoarseness is present with the tracheal deviation, we need to always think about the thyroid malignancy until proven otherwise.
Hold on now. Now tell me the extent of the thyroid gland. From where to where it extends? What is the anatomical extension of a thyroid gland?
It is
Because you have
from
done palpation.
yes, sir. Uh, from C5 to
Can you palpate C5?
no, sir.
Then tell me what all things that you can palpate, and in that relation you tell the thyroid extent. It's simple. It extends from mid of the thyroid cartilage to sternal notch in the vertical extension. Okay. In the
Yes.
horizontal extension, it extends between the two anterior borders of the sternocleidomastoid on each side. Okay.
Okay, sir.
Then so coming to the lower border that we're telling mainly in the palpation. So thing is like this. If you can see the lower border in inspection, then it is done. Okay. If you can't
Yes,
see
sir.
the lower border, then you have to ask the patient to have a sip of water and see whether on declutination whether you can see the lower border or not. Okay.
Sir. Yes, sir.
That you have to confirm again in palpation.
Okay, sir.
Okay. So
Yeah.
tell me the types of retrosternal goiter.
Uh,
So it has two different types of classification. One is primary and one is secondary. So what is primary? What is secondary? Primary is
sir,
the one where the origin itself is in the thorax. Okay. Thyroid
yes, sir.
during development originates and it has blood supply from the aortic arch. Okay.
Sir.
Secondary is the one where there is a thyroid swelling in the neck and it goes into the retrosternal space.
Yes, sir.
Okay. And coming to tracheal position. So usually when trachea, when there is a small quantity of swelling only, you can easily see trachea and you can comment on it. But usually trachea position changes when there is a huge goiter. Okay. When a huge
Yes,
goiter is sitting in front of the trachea, most of the times you cannot palpate trachea. Okay. That times
yes,
you
sir.
can tell tracheal palpation is not possible because of huge goiter. okay, or huge swelling,
Okay.
okay.
Yes, sir.
Okay, next slide.
So we have few methods here. Leahy's method, it is a palpation technique, and here we need to stand behind the patient, and we need to displace the one thyroid lobe towards the midline with one hand, and then we need to palpate the posterior aspect of opposite lobe with other hand, and we need to repeat this on the opposite side also.
Tell
So
me
which
why you
helps
are
us
doing
to
Lahays method.
uh, to detect small nodules, sir.
When you will do it?
Sir,
Like every patient you do Lahays method, or only some patients in some conditions only you do Lahays method?
uh, sir, if the patient have very small nodules, we can do it. So
Oh, it's called classic method. First, whatever you described previously, na, like standing behind the patient, palpating with your fingertips. Okay, this that is called classical method. Okay, so during classical method, you will always palpate the anterolateral side of the thyroid gland. Okay, if you find
yes, sir.
any nodule there, then you will not do Lahays and Kryles and all. Okay, Lahays method you
Yes,
do
sir.
when these surfaces are normal and you want to palpate the posterolateral surface now.
Yes, sir.
Okay, then you will do the Lahays method. Okay,
Okay, sir.
now tell me about Kryles.
Sir,
Tell me about Kryles method.
sir, Kryle's method. We need to palpate the thyroid while the patient is swallowing, sir.
When you will do Kryles method?
Uh, Even in when the patient has uh, small nodules, sir.
When on the classical palpation, when you find there is a small doubtful nodule, you are not sure whether it is a nodule or not. Okay, then you have to do the Kryles method, where you will put your thumb over the nodule and ask the patient to swallow, so
Yes, sir.
that the thyroid gland and the nodules slips under your pulp of the thumb finger. There you can appreciate the nodule better.
Yes, sir.
Yeah. Now Cocker's test. Tell me what is Cocker's test.
Sir, it is a eye sign of hyperthyroidism, sir. Uh, so we need to ask the patient to look straight and uh, look straight and ask them to quickly look upward. So if the upper eyelid retracts suddenly with a jerky movement, and we have a staring appearance, sir. So which indicates a positive cautious test, sir.
Sure.
Like yes, sir.
You think it is uh, long-standing goiter causing tracheomalacia when you move the thyroid to one side causing respiratory distress is a Cocker's test?
Uh, so
Bhargavi, are you there?
tracheomalacia.
Hmm. What is Cocker's test? Long-standing goiter causes weakness of underlying cartilage of the trachea.
Cartilaginous. Yes.
Okay. So that becomes weak. Okay. When this huge goiter is there, it keeps the trachea open by pulling it outwards.
Yes, sir.
When you move this thyroid swelling, that part of the weak trachea gets collapsed.
Okay, sir.
The patient becomes dyspneic. That is called Cocker's test.
Okay, sir.
Okay, what is the significance of it?
Or, so if the Pouch's test is positive, it suggests us the tracheomalacia, sir. So it means the tracheal wings have become weak due to long compression, sir, by the large goiter. It could be due to retrosternal goiters, sir, or
No, it
multinodular
may not
goiter.
be because of retrosternal goiter. It is because of long-standing huge goiter. Okay. So what it will tell us, like during surgery, after removal of this huge goiter, the trachea can collapse because of its weakness. So you may have to do tracheostomy in the same time during surgery, or you have to extubate the patient little late than anticipated. Okay.
Yes, sir.
Move on to Berry's sign then.
Sir, Berry sign is the absence or reduced carotid artery pulsation, sir, over the thyroid swelling. So this could suggest the invasive thyroid malignancy, sir. So it is due to the compression by the large thyroid swelling, sir.
So how do you palpate this carotid pulse?
Uh,
Against which bony prominence do you palpate it?
uh, Sir, the patient should be in an upright position and the neck should be slightly
My
extended, sir.
question, my
So,
my question is
sir, no.
direct. Against which bony prominence do you palpate the carotid artery?
Uh, stern
Is
P6 vertebrae.
Yeah, correct. C6 transverse process of C6 vertebra. It has a tubercle called Chesignes tubercle. Okay. C6
Uh,
transverse process will have a small tubercle. It is called Chesignes tubercle. You will palpate between that tubercle and your finger. Okay.
yes, sir.
And what you will palpate? Common carotid, internal or external? Which artery do you palpate?
Common carotid arteries, sir.
Okay,
Yes.
next one.
Pemberton sign. Um, so here the patient is asked to raise both arms above the head and until they are touched to the sides of face or ears. We need to ask the patient to maintain this position for 1 minute, and we need to observe the patient's face and neck. Is there any facial condition that is flushing, any cyanosis or distended neck veins, or respiratory distress, or feeling of choking or dizziness? So this is Pemberton sign, sir.
Move on.
So for dilation, move on.
Yeah. Tell.
So here the arms are raised because uh, the thoracic inlet becomes relatively narrow, sir, when the arms are raised. So uh, in that case, the retrosternal goiter may then compress. So the trachea will be compressing, causing the breathlessness or stridor, sir. And even obstruction to the great veins could occur, which causes venous congestion and facial flushing, and even neck vein distension, sir. Next slide. So we need to look for the toxic manifestations, and any of myxoedema is present. The swelling is malignant or benign. We need to differentiate by a palpation, and we need to look for any we need to observe any pulsations or thrills are observed over it, and we also need to palpate the cervical lymph nodes. Next slide. So percussion should be performed. The next one. So why do we percuss? Because normally the manubrium overlies the air-filled lungs and the trachea, so which produces a resonant sound. So if the thyroid extends behind the sternum, the gland replaces the air-containing structures and produces a dullness on percussion. So why do we only percuss over the sternum in this thyroid case? Because we could detect the retrosternal extension of the thyroid gland. So if any dullness is indicated, it could suggest us that it is a retrosternal goiter or any other mediastinal mass. Next slide. So next is auscultation, which was performed over both thyroid lobes. So normally there will be no sound is heard, but if a bruit is present, it indicates the increased blood flow. So the most common causes for these are Graves' disease and sometimes a very rare condition, that is very vascular thyroid tumors. So in Graves' disease, we heard this bruit because in Graves' disease, there is a marked hypervascularity of the thyroid gland, so which leading to the turbulent blood flow. So we can observe the bruit in Graves' disease. So the difference
Where
between the thrill and
where do you auscultate? In the neck, in the whole neck, where do you auscultate for bruit?
uh,
No,
sir, I know, sir.
you know or you don't know?
I don't know. I don't know, sir.
Yeah. So you will auscultate at the level of the thyroid cartilage, okay, near to the superior pole of the thyroid. Why? Because uh, you will have superior thyroid artery pedicle there, okay, which is a direct branch from external carotid artery. Okay, there you can hear the bruit. Why not at the lower pole? Because inferior thyroid artery is a branch of thyrocervical trunk, which is a branch of subclavian artery. Okay, and
Yes,
it
sir.
courses behind the carotid. It comes from posterior to carotid and then supplies the thyroid artery. And it always branches into numerous small branches before reaching the thyroid gland. Okay,
Yes, sir.
whereas superior thyroid artery uh, comes close to the gland before branching. So you will have only single pedicle there where you can hear bruit quite well. Okay.
Sir.
Okay.
So on local examination, the thyroid swelling was diffuse, non-tender, firm, smooth, mobile, and moved with dewy glutination. The lower border was palpable. There were no retrosternal extension. No bruit was heard, and cervical lymph nodes were not enlarged. So these findings are a suggestive of a benign thyroid swelling, most likely a multinodular goiter. And next, we need to go for the primary toxic manifestations, secondary toxic manifestation, and metastasis. Next slide. So in the primary toxic manifestations, it is very important because the thyroid swellings are associated with hyperthyroidism, particularly in the Graves' disease. So these signs help us to determine whether the thyroid swelling is toxic and provide provide clues about the severity of the disease. The first one in this eye sign, in that we need to look for lid retraction. So it is one of the earliest sign in the hyperthyroidism. It occurs due to the excess thyroid hormone, so which causes increased sympathetic stimulation of muscles, which elevate the upper eyelid, so making the eye appear more open. The next,
Muscle.
the next,
Which
sir,
muscle is more affected for this lid retraction?
upper
Do you
eyelid.
know the muscle? There are a lot of muscles in the upper eyelid. Main are two: levator palparia superioris and Muller's muscle. Which muscle is affected in thyroid, primary thyroid toxicosis?
Superior tarsal muscle.
No. It is a Muller's muscle. Muller's muscle is infiltrated by the sympathetic stimulus. Okay.
So superior tarsal muscle is also known as Muller muscle.
Yeah.
Yes. Next, we need to go for look exophthalmos, which is proptosis. It is a very characteristic feature of Graves' disease. It occurs because in autoimmune inflammation, there is an enlargement of extraocular muscles and accumulation of some glycosaminoglycans and the fat behind the eyeball, so which making the eyeball pushing it forward. So it doesn't occur in all hyperthyroid patients because it is most commonly associated with Graves' disease and not a feature of all causes of hyperthyroidism. And the next one is von Graves sign, which is like a lid lag sign. So it detects a delayed movement of the upper eyelid. So it occurs because the upper eyelid fails to follow the downward movement of the eyeball because of increased sympathetic tone and orbital involvement. So, how to elicit this in the patient? We need to ask the patient to look down slowly. The upper eyelid lags behind the globe, leaving a strip of sclera visible. So, it is a delayed descent of upper eyelid when the patient looks downward, is the von Graefe sign. The next one is the Geoffroy sign. So, it indicates a reduced forehead muscle activity. So, it occurs because the patient failed to wrinkle the forehead when looking upward due to altered function of the frontalis muscle. So here the patient is asked to look upward and observe the forehead. So if there is an absence or reduction of forehead wrinkling, when the patient is looking upward, it suggests a positive Geoffroy sign. The next is Stelbach sign. So it is another sign of thyroid eye disease. It is like reduced blinking, which is a result of sympathetic overactivity. So if the patient blinks less frequently and produce a staring appearance, it is a Stelbach sign. Next is Mobius sign. So it assesses the convergence of the eyes. So it occurs because of weakness of medial rectus muscles due to the thyroid eye disease, causing the poor convergence. So we will be asking the patient to follow a finger as it moves towards the nose. So it is the inability to maintain the convergence because of weakness of medial rectus muscles. The next is Dalrymple sign. So it helps us to identify the thyroid eye disease. So uh, um, will be asked, it occurs because the lid retraction exposes an abnormally wide area of sclera above the cornea, so giving an staring appearance. And it is a widening of palpebral fissure. Next is the ophthalmoplegia. So, if it is present, it indicates a severe thyroid eye disease. It can be due to inflammation and fibrosis of extraocular muscles, which restrict the eye movement. So, it occurs in Graves' disease, as we know, Graves' disease is an autoimmune disease. So, it enlarges and stiffens the extraocular muscles and limiting the movement. Next is chemosis. So, it indicates the active orbital inflammation. So it can be seen inflammation and venous congestion, which causes edema of the conjunctiva. So chemosis is nothing but a swelling or edema of the conjunctiva due to the inflammation. Next slide.
Now, Bhargavi, tell me what are the importance of this? These many eye signs are there. What is importance of these eye signs?
Uh, Sir, it helps us to uh, like some eye signs are very classic in thyroid disorders, like in hyperthyroidism. So we can get the probable diagnosis through these eye signs, sir.
Few eye signs are pathognomonic. Means if they are there, then it is surely hyperthyroidism, mostly Graves' disease. Okay.
Yes. Uh, Next is tachycardia. As we know, it is a most common cardiovascular manifestation hypothyroidism, as the thyroid hormones increase the beta adrenergic receptor sensitivity, so which is leading to faster heart rate. So as excess thyroid hormone when present, there's an increased sympathetic responsiveness and cardiac stimulation. And the next is tremor. So the fine tremors is a characteristic sign of hyperthyroidism. And in the it's the same, it is due to the enhanced beta adrenergic activity, which increases the muscle excitability. Therefore, fine tremors occur. So we need to ask the patient to stretch out the both hands with fingers spread. So we can look for tremors. So
You see those
in
fine tremors with outstretched hand. You
sir,
can't appreciate it better unless you place a paper over this outstretched hand. Okay. There
okay,
are
sir.
fine tremors. It is very difficult to identify while examination and all. Okay. You have to place a paper. So when there is small fine movements also, the paper will shrivel a lot. Okay. What is the
Yes,
other
sir.
place that you can check for these fine tremors other than hand?
Uh,
Can check in the tongue. Okay. You have to ask the patient to open his mouth and keep his tongue inside the mouth only. Okay. If he protrudes the mouth out, there will be intentional tremors. Okay. You have to ask the patient to just open his mouth and see the tongue, which is at the resting phase. Okay. There the
yes, sir.
tongue will have some fine tremors. Okay.
Yes, sir.
Next.
Uh, we need to see if the skin is moist and warm. So if the skin is moist and warm, it suggests increased metabolic activity. So when there is an excess thyroid hormone, it increases the heat production and sweating. So the increased metabolism produces more heat and sweating. So thyroid root, it suggests increased blood flow through the thyroid gland. So it occurs in Graves' disease usually. So the thyroid becomes markedly hypervascular as we discussed before. So which creates a turbulent blood flow that can be heard with a stethoscope. So it is classically heard in Graves' disease because of increased vascularity of the thyroid gland. Next slide. So secondary thyrotoxicosis. Um, there will be cardiovascular system is mainly affected as we have discussed before, and atrial fibrillation is more common and heart is enlarged. The signs of cardiac failure will be seen here. So uh, because secondary thyrotoxicosis is due to prolonged thyrotoxicosis which affects the heart, and in tachycardia is usually the earliest and most common cardiac manifestation that occurs. It is due to beta adrenergic receptor sensitivity, and atrial fibrillation occurs as we have already discussed about it. So excess thyroid hormone increases atrial excitability and shortens the refractory period, so which predisposes to the atrial fibrillation. Uh, the signs of heart failure will be seen. Next slide. And next, we need to search for metastasis. If thyroid swelling, when you palpate, it is a stony hard, irregular, and is fixed to the surrounding structure. So it raises a very strong suspicion of thyroid malignancy. So in such cases, we would actively search for evidence of metastasis, especially like bony metastasis, because most of the thyroid cancers, particularly the follicular thyroid carcinoma, commonly spread through the bloodstream to bones. So we need to suspect malignancy in case of this stony hard consistency and irregular and fixed to surrounding tissues.
Can
And
you tell me
it is,
what type of Bhargavi, can you tell me what type of bony swellings you get in follicular thyroid cancer?
sir,
What kind of bony mets you get in follicular thyroid cancer? What type? Osteoblastic, osteolytic, what kind?
uh,
Get
Sir,
pulsatile,
osteolytic.
osteolytic. You get pulsatile. Only two types of cancers you will get osteolytic pulsatile bony swellings. One is follicular thyroid cancer, other one is renal cell carcinoma. Okay.
Okay, sir.
Yeah. Mostly you will see in scalp.
Okay, sir.
Okay. Next.
Next slide. So so after this all we need to go for the investigations. The blood investigations like complete blood count, blood grouping and RH typing, renal function test, liver function test, blood sugars and coagulation profile.
I
Next
say I
slide.
don't have money. Listen, if I say I don't have money for all these blood tests, sir, I have only money for left only for one blood test. So tell me one important blood test that a thyroid swelling patient should have. Only one, which will help
Thyroid
in management.
function. Thyroid function test, sir, for the levels of T3, T4.
And I don't have money for T3, T4 also. The other thing left in thyroid function test.
TSH levels.
Right. TSH is the single most, if the examiner asks you, tell me one blood test that helps in management of thyroid evaluation, thyroid swelling evaluation, you should tell TSH first.
TSH. Yes, sir.
Okay.
Yes,
How
sir.
it will help? How it will help? Only TSH.
Sir, if there is an elevated levels of TSH, it indicates that hypothyroidism, sir, as the T3, T4 hormones will be less in blood in hypothyroidism case, sir. So the anterior pituitary will be releasing more TSH and the levels will be increased, sir. So via that we can we can diagnose the patient, sir.
More important is to diagnose the condition called hyperthyroidism. So when the gland is hyperthyroid, you will not do any FNAC or anything. Okay, you will wait, you will settle that hyperthyroid condition first. Why?
I have no
Because
ideas.
because in hyperthyroid state, the gland will be very vascular. Okay, when you
Yes,
try
sir.
to put some needle, it will bleed, and all the thyroxine that is stored inside the thyroid gland will come out, and patient will have condition called thyroid storm. Okay.
Yes, sir.
Okay, go on, carry on.
Yes, sir. So the next is thyroid specific investigation. We need to uh, uh, know the levels of TSH, free T3 and free T4, ultrasound of the neck, FNEC, laryngoscopy, that is indirect or flexible, CT scan if indicated, and thyroid scan.
Okay, now tell me, uh, ultrasound neck. What do you see in ultrasound neck? What grading that you will
Uh,
give?
Sir, in that we'll be assessing the thyroid gland size, shape, if there is a diffuse enlargement or nodules are present, sir. Uh,
Hmm?
and uh,
So
sir,
have you
we have
heard? Tell me.
sir, we have 5 grades, sir. Uh, so in the grade 1, there'll be no nodule is present, sir. It is a normal thyroid. So we can know it is a benign one. And in grade 2, we can see a small nodules or cyst like, sir. Whereas in 3, it is a probably benign, mildly suspicious features will be present, sir.
Hmm?
And in 4, there will be irregular margins and some calcifications can be present, sir. Whereas in the
Hmm?
grade 5, it has uh, very irregular, sir, calcifications are more, and extra thyroid extension is more seen, sir.
You know what this classification is called as? This grading is called as?
Yes, sir. It is TRATS concept. T.
What is full form, you know?
No, sir.
Called Thyroid Imaging, Radiology and Data System. Just like in breast we have BIRATS, the same thing American Thyroid Association has built up with, came up with this grading called TIRATS. Okay.
Yes, sir.
Okay. So how do you decide which nodule should be FNA? You find a nodule, you ask for FNAC, or you will have any criteria to decide which gland should, which nodule should go for FNAC?
Sir, only in grade 5 we ask to go for FNEC, sir. Because in grade 5 we have high suspicious of malignancy. So
Okay.
we'll be having it in grade 5, sir. Yes, sir.
Not in grade 5. It depends upon, it's a combination of the size and this thing. Okay.
Yes, sir.
For if you have grade 5, even 0.5 centimeter nodule, you should do FNAC. Okay. If it is grade 4, 1.5 centimeter nodule should be undergone FNAC. So if it is less than 1.5, grade 4, you can still ask for follow-up if patient is willing. Okay. In grade
Sir.
1 and 2, you will not ask for FNAC at all. Okay.
Yes, sir.
Right.
Next slide.
Why do you do flexible
Sir.
laryngoscopy? Go back. What is the importance of indirect or flexible laryngoscopy?
Sir, it helps like we can visualize the larynx and vocal cords and pharynx, sir. So
Hmm?
if there is a hoarseness of voice or any laryngeal paralysis has occurred for the thyroid surgery evaluation, we can look for it, sir. Like it even checks the recurrent laryngeal nerve function indirectly, sir.
All before, it's for mainly to saving the surgeon's life from medical legal aspects. Okay.
Okay, sir.
So you have written CT scan if indicated. What are those indications?
Uh,
You know or you don't know?
yes, sir. CT, in trauma, we'll be using it, sir.
Tell me in case of thyroid swelling only without trauma.
Uh,
That is more
in
common. A
in
trauma with thyroid swelling, I think I have never seen in my life until now.
Yes, sir. In retrosternal goiters or thyroid cancers and tracheal compression or deviation will be going for the CT scans, sir.
If there is any big mediastinal extension, if the thyroid retrosternal goiter is big and extending deep, you should get a CT scan to see the extent of the thyroid into the mediastinum.
Yes,
Okay.
sir.
Another thing is like bulky nodal disease. Okay, if there is a big nodal disease, you have to get, or if you see if the skin is attached to the thyroid gland, or if there is, you think strap muscles are invaded on ultrasound, all these extra thyroidal extension, you need to get a CT scan. These only three indications: one extra thyroidal extension, one nodal disease, one bulky thyroid. Okay. Okay. Next.
Next slide. So it is a summary table for the differential diagnosis of thyroid swelling. Uh, so the first one is the multinodular goiter. So it is usually seen in middle-aged or elderly female, which is a very slowly progressive swelling and with no pain and usually euthyroid. So on examination, we'll be finding nodules and which moves with swallowing and surface is nodular and non-tender and the lower border can be palpable. So for this, the investigations we could do is TFT, USG and FNAC. So the most common in areas of iodine deficiency and nodular surface, long standing. And the next one is the colloid goiter, which is usually seen in middle-aged or females, and middle-aged females, which is a very slowly progressive, and there will be no symptoms of thyroid dysfunction. And on examination, we'll be finding that there's a diffuse enlargement with smooth surface, which moves with swallowing, non-tender. It could be soft or firm. So we'll be doing the investigation such as TFT, USG, FNAC. In FNAC, we'll be seeing a colloid goiter, whereas in USG, we'll be seeing a diffuse enlargement. Next one is a solitary thyroid nodule. So this solitary thyroid nodule could occur in any age and in any sex. It is a painless swelling, and there will be no symptoms in early stages. So in the examination, we'll be finding a single nodule which moves with swallowing, and the consistency is variable and usually non-tender. In the Graves' disease, we'll be mainly seeing the weight loss, palpitations, tremors, heat intolerance, and menstrual irregularities, as it is a hyperthyroidism disorder. So, on examination, we'll be finding a diffuse goiter, warm and smooth gland. Thyroid root is present because of hypervascularity of the gland, and Hashimoto thyroiditis. In this case, as it is a case of hypothyroidism, we'll be seeing easy fatigability, weight gain, cold intolerance, and menstrual disturbances. So on examination, we'll be finding a diffuse form enlargement, surface usually smooth and non-tender. And in the case of thyroid cyst, there'll be a sudden increase in size, and it is a painless one. So on examination, the consistency is soft, which has a fluctuant swelling, smooth and usually non-tender. Coming to the thyroid cancers, it rapidly increases in size with pain or hoarseness in later stages. Pressure symptoms like dysphagia, dyspnea, hoarseness of voice, and stridor could be observed here. So on examination, it is a very hard swelling, stony hard with an irregular surface, which is fixed due to the invasion to the adjacent structures, and cervical lymph nodes could be palpable, and tracheal deviation is possible, which causes dyspnea. And the last one is the thyroglossal duct cyst. So this is a swelling since childhood or adolescence, and may increase with upper respiratory infections. So we need to differentiate the thyroid swelling from this thyroglossal cyst by the simple test like protrusion of the tongue. So only the thyroglossal duct cyst will be moving upward with the protrusion of tongue, and it is not related to swallowing.
Okay. A long list of differential diagnosis. If you
Sure.
ask me, it's a long list of differential. Yeah.
Sir, I'm sorry to disturb, sir. Sir, since the time is getting over due to time restriction, can we wind it up faster?
We can wrap.
Sorry, sir.
Yeah.
So sorry, sir. Thank you, sir.
It's okay. Thank you. Thank you, everyone. Bhargavi, you have done well. Very much informative PPT you have made. All the best.
Thank you, sir.
Thank you all, and happy Doctor's Day.
Thank you, sir. Happy Doctor's Day, sir.
Thank you so much for everyone. I thank Dr. Aditya sir for his presence and valuable information. And I also appreciate Bhargavi from 2023 batch for her amazing performance. Let us end the session with NMO Shanti Mantram. Om Sarve Bhavantu Sukhinah, Sarve Santu Niramayah, Sarve Bhadrani Pashyantu, Ma Kaschit Dukkha Bhagbhave, Om Shanti Shanti Shanti. Thank you, everyone.